Welcome to the Diabetes UK and British Islamic Medical Association Preparation for Ramadan webinar. My name is Aoife Slattery, Tackling Inequality Engagement Lead at Diabetes UK. This webinar was originally recorded in January 2024 and has now been updated in January 2025. This webinar is intended for healthcare professionals supporting patients through Ramadan. If you're not a healthcare professional and you would like to access advice and support for fasting during Ramadan, please visit diabetes.org.uk/Ramadan, where you'll find support including fact sheets and bite-sized videos, including in other languages, to support anyone living with diabetes during Ramadan. Bilal Aksi will now share his experience of living with type 1 diabetes and fasting during Ramadan.
Hi, first of all, my name is Bilal Aksi. I'm type 1 diabetic. I've almost been diabetic for 9 years. By profession, I'm a gas engineer, so I'm always active within my work and deal with type 1 diabetes at all times. When the first Ramadan came round, for me, in my culture, in my kind of background, in my upbringing, Ramadan is like second nature for me. I don't think twice about it. So when I was diagnosed with type 1 diabetic, I actually just start fasting without realising or without asking any sort of professional help, because I didn't think anything of it. Because when I got diagnosed, Ramadan kind of started quite fairly soon after that. As I was fasting through, it was actually helped my diabetes, because my basal and bolus had to kind of reduce my insulin down, especially my basal background insulin, had to reduce it down to stabilise it. And when I told my professional body that I was fasting, they were kind of surprised. They were like, "What do you mean you're fasting?" I'm like, "Yeah, I'm just fasting." And they're like, it is one of those kind of things. They didn't realise type 1s could fast, or they didn't have the kind of right solutions or the answers for it. And I didn't think anything of it as well. Being naive, being new to type 1 diabetic, I didn't think anything of it. I did have a few hypos. Obviously, I treated them at the time. The good thing is, especially with my religion, I'm actually exempt for fasting, but because of the love I have for religion and the passion behind it and the benefits from fasting, that's why I kind of continued on fasting with that as well. Now there's a lot more resources from when I've started, so there's a lot more knowledge, a lot more information out there for type 1 diabetes. And I think a lot more people are aware of it, which is quite refreshing, quite nice, because Ramadan is it's effectively like a restart button for myself. It just to refresh my body, my mind, my soul, everything that comes with it. What the challenges that are faced, what the common anxieties people might face, I think that a lot of people that don't talk about it, the anxiety they kind of face on a day-to-day basis with Ramadan, especially leading up to it, is the fact that they want to talk to a professional body or someone that has an understanding and being comfortable with them to be openly talking about it, rather than kind of being a taboo subject about it. Even myself, I know people that maybe still do fast, but don't tell their professional body or the doctors. And reason being is just an uncomfortable thing that they might not understand, or they don't know the concept behind it, or they don't know the reasoning behind it. But this is where professional clinics should take a step up and learn and understand this, because there's different faces, different backgrounds, but this is specifically for Ramadan, and you want the person, whoever is coming to you, any patient that's coming to you, to be comfortable in that room, to openly talk about being judged. See, especially nowadays, you need to be really open-minded with everything that's going on. Yeah, you want the patient to feel comfortable with any practitioner, with any professional body, to openly talk about it. Just read up on that, just get a basic understanding. And if the doctor's unsure, like us as Muslims, we like when people ask us questions, it's just out of curiosity, awareness. So the religious perspective, by all means, ask. But when it comes to the kind of professional perspective, that's where the doctors need to step up and think, right, where can I give exception to this, and where I need to give exemption to this. So just try to broaden that kind of mindset towards it.
Our healthcare professional speaker, Dr. Nazim Ghouri, will now share his top tips and evidence-based advice for supporting patients during Ramadan. Dr. Ghouri is a consultant physician at the Queen Elizabeth University Hospital in Glasgow and an honorary clinical associate professor at the University of Glasgow. Dr. Ghouri has published over 50 papers and has also studied sacred Islamic knowledge with a contemporary focus. His research and teaching interests relate to his clinical and academic expertise, as well as ethnicity and faith, particularly fasting in Ramadan. He is the joint senior editor of the British Islamic Medical Association Ramadan Compendium.
Thank you very much, Aoife, for the introduction. And as mentioned, I'm here today to just talk you through managing patients with diabetes during Ramadan, but also at other times of the year when they might be fasting, so principles can be applied throughout. As mentioned, I'm from Glasgow, and I have been fortunate to have done this webinar the year before, and this time round we're just updating things, particularly as dates have changed and timings have changed slightly as well. The agenda, similar to last year, will summarise the latest Diabetes and Ramadan International Alliance guidance. This is advisory and this is not prescriptive, but rather guidance to guide individuals. It's not prescriptive or compelling in any shape or form, but nonetheless provides a basis for managing patients during times of fasting. And to help understand this, I'm going to take our Greater Glasgow and Clyde NHS guidance that I am the author for, which applies these guidelines and others in a practical manner to give you a flavour of how to manage patients during Ramadan or indeed fasting. So we'll cover some basics first. For example, what does fasting Ramadan actually entail? And then what every healthcare worker should know about Ramadan from the religious perspective, but also from the medical perspective, and then taking you through that journey about you and your patient. Our responsibility, I think we all have a responsibility to look after our patients, and part of that is to understand the ideas, concerns and expectations patients may have of us as healthcare professionals. And it's interesting to note from around 2010, from some qualitative data, that patients who were surveyed were a bit skeptical, a bit hesitant about the understanding the healthcare professional may have about Muslims and faith-related matters when it comes to their health or illness. And there was also a feeling that perhaps they weren't willing to engage in discussion on these matters because it may affect a patient's engagement with treatment or indeed the confidence they have in the healthcare professional. So a seminar, or rather a webinar like this, helps bridge that gap and put both parties at ease. So some definitions to help us get started. Ramadan itself is defined from a legal perspective, a religious legal perspective, as one of the 5 religious pillars. It's an obligation. What that means is that for the person who takes the obligation seriously and wants to fulfill them, it involves no drink, food or drink, or anything that enters the GI tract, or any marital relations from dawn to dusk for 1 lunar month. And that's 29 or 30 days. And from practical terms, that's from the start of the morning prayer till the start of the post-sunset or the 4th prayer of the 5 daily prayers. And it's obligatory for anyone who's attained the age of puberty, is mentally sane and is physically capable of fasting. Terms that we use when it comes to Ramadan or fasting, we use the word suhoor or the sehri, which is the Arabic word for a pre-dawn meal or food consumed before the fast starting. The iftar or the meal or food consumed when opening the fast at sunset. Sharia is a term that's used for religious or sacred law. So we talk about a Sharia ruling, for example, we are talking about the Islamic perspective in terms of the do's or the don'ts or the cans and the can'ts. But for the Muslim, it's not just about what I mentioned before, but it also has a large social component to things as well, and a spiritual component as well. What that means, for example, in the latter, it means exerting yourself a bit more and trying to pray a little bit more, particularly at night. And from a social perspective, often the opening of the fast will be involved with getting together with family and friends, or as a community, as you can see with one of those photos, and sharing food. Now, eating together as a group of friends or family is by no means something that we should be worried about, but actually celebrate and encourage. And it's about doing it in a healthy way that ensures that the essence of Ramadan is maintained without compromising health. So how long does a fast last? So if you were to go back maybe 5 or 6 years, or even going back even as far as 2017, fasts were pretty long throughout the UK. In essence, they're pretty much over 18 hours from dawn till dusk. There are geographical minor variations depending on methodology to calculate, but you can see the fasts were pretty long. And just to give you context, just a couple of years ago, it had already fallen to around 13.5 hours at the start of the month in London and moved up to around 15 hours So the days get longer over the month, particularly when you are on the January side of the shortest day of the year. When Ramadan falls before December, the days will actually get shorter until you get to the shortest day of the year. So over the next 5 years to set the scene, so this year we're pretty much looking around about 14.5 hours at the start, for the longest fast rather. So the fast will start shorter and reach our peak at the durations shown, but in 4 or 5 years time, that will be even shorter, i.e. you'll be looking at less than half the day of fasting, which changes things from a perspective, from an opportunity to fast, particularly those people who are not able to fast when the days were longer. And you can get prayer times and get a feel for the duration of the fast in the different parts of the world by visiting the website below. Is Ramadan a big issue? Am I making a big thing out of nothing? Well, to give you a context in terms of the Muslim population in the UK, we have around 6.5% in England and Wales, and around 15% in London if you look at the latest census data. And if you look at Glasgow, where I'm from, it's around 5.5%. So you're talking anywhere from from just around 1 in 20 to almost 1 in 6 to 1 in 7. The majority are of a South Asian, that's usually a Pakistani and Bangladeshi or Indian Arab background, and they account for around 3.2% of the UK population. South Asians and Arabs are associated with an increased prevalence of type 2 diabetes. So the groups that we're kind of focusing on, their risk of diabetes is higher than the white population. We also know that for South Asians in particular, that they're associated with poorer control, and that also includes problems with complications. And from a global perspective, we know that around 90% of Muslims fast. So fasting is one of these obligations that people will make an effort to try and fulfill. Is there anything to worry about? Well, there's a few things that come to mind when we start looking at fasting. The risk of hypoglycemia, particularly in temperate regions when the fasts are longer. So, for example, the part of the world that we're in the summer, as I showed, the fasts are pretty long, and that will come with a risk. Muslims are generally optimistic about their well-being when it comes to fasting in Ramadan, but nonetheless, many individuals who have been advised not to fast by the healthcare professional may still choose to do so. And we also have to factor in secular legislation as well. For example, when it comes to the DVLA and the standard or expectations for glycemic level and safety management when driving. And we know that from other data around the world that driving during Ramadan is already associated with increased risk of sleep-related road traffic accidents. And that, if you remember, will probably be related to the fact that people might be up during the night saying extra prayers, going to bed late, or indeed just not used to waking up and having something to eat before, so their sleep cycle might be affected initially. But we know that individuals who received Ramadan-specific information did better at following Ramadan-specific diabetes recommendations. And that included monitoring their blood sugars and appropriately altering the dose and timing of medications, and breaking the fasts if they developed symptoms that were of cause for concern. Is there anything else? Well, just like any other patient who has diabetes, they may also have other illnesses as well, or ailments. They might be on multiple drugs. They could be frail. There could be an element of cognitive impairment, and some or all of these factors need to be factored in. As I touched upon, driving is an area which you have to factor in because of the other legal perspective and the risk to the individual and other road users. And it's important that whatever we do with our individual patients, we have that consultation, is that we have to do it in a sensitive manner and a way that's reflective of what's important to the Muslim, and it's harmonious with the secular and religious particulars. So as mentioned, when it comes to the general kind of population, and diabetes is around maybe 5%. When it comes to Muslims, they occupy a greater percentage, relatively speaking, when it comes to fasting. So they are a population or group that do deserve some time and attention. As with any obligation in the religion, there will be concessions and exemptions and dispensations, and fasting in Ramadan is no different. So, as taken directly from the verses in the Holy Quran, which is a Muslim holy book, If an individual is unable to fast due to travel or to illness, then should try and fast a like number of days when they're able to do so, i.e. at a time of year when it might be safer and conducive to fasting. However, if you're unable to fast at all, then potentially you can feed a poor person for every day that you do not fast. And this is specifically when it comes to a perpetual or permanent state of affairs that prevent an individual from fasting safely, or harm will be occur if one fasts. And the important thing to understand is that it very explicitly states that God does not desire difficulty on you. He desires that you should complete the number, meaning that making them up, or by feeding a poor person. It's very important to grasp this point because many Muslims, for example, will feel that not fasting is seen as a lesser option. What I explain to my Muslim patients, and when I'm giving this talk to people, explaining to them about Ramadan, whether it's Muslim or not Muslim, is that the important thing to understand is that the essence of fasting is to acquire this concept of God consciousness. And that means putting God at the forefront of your mind, not at the back of your mind. So if God desires you to fast, you fast. But if there's been a valid dispensation explicitly stated and you fall within that, you don't fast, because your fasting in many ways is not fasting because you're trying to please God. And the pleasure of God should be at the forefront and the purpose of a person's actions. And therefore, if they've been advised not to, or they know that their health is at stake, or they've got frailty, and that fasting may harm things, God is not in need of the fasting. What he desires to seek or to see from the individual is that submission and that putting him first. So for many individuals, that decision of not fasting can be a very difficult one to take, but nonetheless, if they understand they're pleasing God by it, it makes it easier, and they understand the concept of the fact that hunger is not what reaches God, but the piety of the individual does. So when it comes to this concept of sick leave, to break it down, it's an ailment that worsens through fasting, especially if causing irreversible damage or causing significant impairment. And this includes old age and frailty. An ailment, the healing of which is delayed by fasting, or a legitimate fear or concern of either of the above two. And what do we use to determine the application or taking the sick leave allowance? It's if you've got prior experience of what fasting does with when having that ailment, so you know you get worse, so you don't get better. It's common knowledge. So, for example, a person with Addison's disease who does not take their steroids, they will become more unwell, and this is specifically relevant to those that perhaps take hydrocortisone 2 or 3 times during the day when fasts are longer. Or the opinion of a qualified Muslim physician on the matter. So that legitimate fear could be based on the fact that they've been advised by somebody, or they know from the common knowledge or the prior experience. So dispelling some myths, because it's important to myth bust before we move any further forward. What that means is that simple questions like, can a person take subcutaneous insulin while fasting? The answer, of course, is yes, because I made specific reference to the GI tract as a reason of, that would break the fast. Anything that's of nutritional value given through intravenous route, according to many scholars, would also break the fast as well. And if you want to know more on drug routes and of administration, we've got the BMJ paper from 2004, and there's also a reference in relation to a BMJ educational piece, which I'll show at the end, from 2022. A person can't break their fast if they become unwell. Pay attention to the wording. Of course, that is not true. They can break their fast because, as mentioned by the verse, and pregnant and nursing mothers have to fast. Emphasis on the wording there as well. Again, no, they don't. Not if there's a risk to the mother and or baby, and it comes back to the 3 criteria that I showed earlier. In terms of the guidance on management of diabetes in Ramadan, there's a number. As I mentioned, we have the International Diabetes Federation and the Diabetes in Ramadan Alliance practical guidelines. Latest version is 2021. They will be up for renewal probably within the next 12 to 18 months. Broadly, I don't expect things to change much, but the latest guidance is available. And there are a number of papers, as I mentioned, the paper in the BMJ from 2022, the best practice guidelines, which again looks at chronic disease management, which not just includes diabetes, but other important factors such as polypharmacy, frailty, old age, and indeed multimorbidity. There's another review paper which goes through the DAR guidance and also this expands on it a bit in terms of some of the things in relation to alternatives to fasting on a consecutive basis, as also outlined in the paper above. I've done a piece on understanding the discourse when it comes to driving, for example, and it's a useful paper if you want to understand how religious and secular law interact, or the interplay between the two. Many of your trusts will have their own guidelines. Broadly, will be very similar and will be based on the first reference I've mentioned on this slide. And Diabetes UK also have guidance, and the links of which will be at the end of this presentation. The common messages tend to be plan for Ramadan in advance, to risk stratify your patient. In terms of looking at the grading, would you say grade 4 evidence is probably how you'd class the IDF DAR tool. So this is largely based on expert opinion. Whilst it is not the strongest of evidence and by no means compelling, nonetheless, it does factor in the expertise and experience of those individuals who are healthcare professionals who understand fasting and have managed patients during Ramadan or fasting. Trial fasting is an emerging concept that is coming out more to help patients get a feel for how Ramadan may go for them, and equally allows them to kind of prepare for the month by having some trial fasts in the weeks preceding. Lifestyle advice and targeted education. And again, when it comes to treatment options, is any change needed? Do you need to modify or change things? And the final common message is ultimately it is the patient's choice. We can advise and we can certainly share our concerns or indeed our support. However, it's the patient's choice at the end of the day, and it's important with this in mind that everything is documented in terms of consultation, in particular when there's a dichotomy between what the patient wishes and what the healthcare professional advises. This is the QR code as well as the URL at the bottom of which, in relation to the Greater Glasgow and Clyde Ramadan guidance that we currently follow. And the reason I'm sharing this is because I'll be going through this, but broadly speaking, a lot of trust guidelines are very similar to this. The one thing, as I mentioned before, is the preparation, which should be around 4 to 12 weeks before Ramadan, hence the timing of this presentation. And ultimately, you're there to risk stratify your patient, factoring in their views, their concerns, their ideas, their aspirations, their prior experiences, to risk stratify them, to provide appropriate education for the individual, whether it's a group-based activity, whether it's virtual education, or it's tailored to the individual, or a combination. And generally, patients will be stratified into one of 3 groups. Now, the most recent DAR guidance prefers to use the term low risk for the lowest risk, moderate risk, and high risk or very high risk. The previous guidance put moderate and low together, high and very high. Bottom line is there will be 3 categories: a lowest risk, and a highest risk, and a moderate risk group. Generally, the lowest risk group, individuals would be allowed to fast with appropriate preparation. In the moderate risk group, generally to be advised not to fast, even if they are following safety advice, they might still be advised not to. The highest risk group, regardless of which guideline you look at, the general advice is they shouldn't fast, so a stronger emphasis on not fasting. Again, as I said, you want to factor in whether the individual wants to fast or not. The concept of trial fasting, does a dry run give you a valid piece? Does it provide a valid bit of evidence to show that either fasting might be good one way, or if not? They want to discuss the issue with a Muslim physician. And the reason I say that is historically, you would speak to a Muslim physician on whether you, when getting or acquiring advice on whether making a decision on fasting would be safe or not. Obviously, not everyone can access a Muslim physician, and equally, not all Muslim physicians are clued up when it comes to the different ailments out there. Hence, we have these types of sessions and guidance out there to bridge the gap, and therefore the guidance that's followed can be followed by anybody, but ultimately applies Islamic principles. Sometimes individuals want to speak to a trusted religious authority, like an imam or a scholar, particularly being advised not to fast because in their mind they're not going to be able to fulfill an obligation. Again, the imam themselves, they might actually say that they are not the best person to advise because they don't understand the medical side, but nonetheless they do appreciate people will come to them, so they will often direct traffic back. But what they will often say is that they'll say that whatever your healthcare professional advises, we will be supporting all of that. A chance to lose weight or stop smoking. Meal timings, because obviously timings will change depending on the keeping of the fast and the opening of it. And also equally within that, individuals may eat more at one meal than at another meal because of patterns of behavior might change. They may want to consider secondary care referral for more complicated or complex cases. Important thing to understand is sick day rules do not change when it comes to type 1 diabetes, for example, when it comes to hypoglycemia in particular. Hyperglycemia, again, very much depends on the individual, baseline sugar control and degree of ketosis. Emphasizing that illness and safety are valid and encourage those regions to terminate the fast or abstain from further fasting. And again, if there's recurring or persisting circumstances, then perhaps not fasting at all might be the option that has to be applied. In terms of risk stratifying your patient, these factors that are listed basically are the things to think about, and I've touched on pretty much all of them already. In terms of the previous DAR guidance, which was table-based or tabular in terms of putting the individuals to different risk categories, you'll see that it's pretty commonsensical in terms of the fact that those, for example, are just on lifestyle therapy and metformin are seen as the safest and potentially can fast. Those individuals that are having severe hypoglycemia, are acutely unwell, have poorly controlled type 1 diabetes in particular, they're classed at the highest risk. But remember, for any of the categories, even if you're advising them one way or the other, the important thing is to ensure that the advice in the comment section is provided to keep everyone safe and above board. In terms of the more recent DAR guidance, it's moved to a scoring system because generally scoring systems might be a bit easier to apply. And there's a number of areas that are covered, range from the diabetes type and duration, all the way down to the fasting hours. Now, these questions were derived by a group of experts. The scoring is based on the opinions of healthcare professionals who took part in a voluntary questionnaire in terms of how they thought the risk might be. It's not very granular, and it's a good starting point for individuals, particularly if you're just trying to get a ballpark or feel for things, but by no means is it something that's definitive or binding. In fact, I do think perhaps that for many individuals it might overestimate risk, particularly when we have certain factors in play that might make things protective. Equally, when it comes to the length of fast, simply splitting into 16, more or less than 16 might not be enough. Perhaps you need 3-hour windows as opposed to the windows stipulated. And like I mentioned, the higher the score, the higher the risk. Lower the score, lower the risk. And again, the associated comments that pertain to the respective risks. When the fasts are longer, it might not necessarily be relevant to fasting in the UK this Ramadan or even for the next few years. Individuals may nonetheless wish to do voluntary fasts. Indeed, a number of individuals will fast up to 6 or more days in the subsequent month, and indeed fast throughout the year. So the important thing to understand, these risks, although might not be present for Ramadan, might still be present when it comes to religious fasting, and these include dehydration, risk of metabolic upset, particularly if sugars get very high with dehydration, high blood sugars, and low blood sugars. The data that underpins is actually quite weak in terms of the exact risk involved, but nonetheless, these are risks that have a basis and should be thought about and discussed. With the new tool, as I mentioned, I do think it perhaps overestimates risk, and we have done an editorial on this piece, just highlighting some of the fact that risk might be overstated, and I've listed them there. And that includes, for example, the use of an insulin pump, flash glucose monitoring, a supportive team. All these things reduce risk, but equally, a prior negative experience of safe Ramadan might actually increase the risk because they might have a psychological impact. And what I have done in our local guidelines is I've tried to marry between the newer guidance as well as the pre-existing guidance, and also when it becomes apparent that perhaps the risk is perhaps being overstated. And this flow diagram is quite useful just to help navigate that risk in terms of downgrading risk. But the important thing is that you should always document your consultation and the discussion that was undertaken. There are other opinions on type 1 diabetes, and there has been a paper published in Lancet Diabetes and Endocrinology, and this is more UK or tech focus, which factors in things such as pump therapy, closed loop systems, flash glucose monitoring, and education, which all can lower risk, and therefore fasting might be actually a very viable option for a number of people that might be excluded based on international guidance. And to be fair, the international guidance does state that local guidance might be needed based on specific local factors at play. So the trial and voluntary fasting, you've heard me mention this on a couple of occasions. And this is something to help bridge that gap when it comes to removing uncertainty and giving confidence one way or the other when it comes to fasting or otherwise. And it allows the individualized risks to be assessed, particularly if it's a new condition that has emerged since the last Ramadan, because at the end of the day, people do get older, things can happen over a 12-month window. That can include medication changes as well. And equally, if medication changes are subsequently needed for the fasting itself, this allows you to make those changes, see how practical it is and how safe it is. Also, it helps an individual understand the risk of dehydration and adequacy of nutritional changes to allow for acclimatization, that's the body getting used to things, and to assess whether complications may arise, for example, deterioration in glycemic control. So it gives a bit of fine tuning to be done if these voluntary fasts are done with 2 or 3 weeks in advance of the month starting. And here's some guidance in terms of how to undertake it. And the BMJ guidance by Mahmoud and colleagues in 2022 is an excellent resource in terms of going into things in more detail. The beauty of a trial or a voluntary fast is seen as voluntary, so breaking it, the same rules apply, but often individuals might find it's easier to break the fast because it's not obligatory, so there's a psychological burden that's a lot less than perhaps if you're doing an obligatory fast and doing this for the first time when the month starts. Alternatives to consecutive daily fasting. Again, always comes back to the 3 criteria I mentioned in terms of whether it's safe or not for an individual to fast. It might mean that they can't fast all 30 days consecutive or 29 days consecutively, but they might be able to do a few days at a time and take a break and resume. So in that way, they at least are able to participate in as much of the month as safely is possible to do so. They can make up the subsequent fast, for example, in the winter months, when the fast could be as short as 10 or 11 hours. They might not be able to fast at all in the longer months, but when they do hit the winter months, they can fast all of them. So it might even be a more kind of binary switch. If there is a perpetual or permanent circumstance that arises that prevents an individual from fasting, then paying the fidya or feeding a poor person for each day you don't fast is an alternative fasting. And in such a circumstance, you really wish someone to discuss this matter with a religious authority that they may trust, so that they are doing things responsibly and without feeling unnecessarily guilty as well. In terms of some of the specific international guidance that's out there, the hypoglycemia advice makes sense and is and should be followed at all times. When it comes to higher blood sugars, they say to break the fast if your blood sugar is more than 17. Now, for a number of individuals that will fast anyway, their sugars will be over 17. So what I often say is that it's whether the 17 is something that is normative or happens frequently or less frequently. If it's less frequently or doesn't happen at all, this may indicate that the individual might actually be becoming more unwell, maybe picking up an infection, so it could be a marker for something else. And the important thing is common sense should be applied, and the concept of checking blood ketones or urine ketones should also be used to help manage risk. A number of individuals are on SGLT2 inhibitors, be it for glycemic or diabetes reasons or otherwise, such as renal or cardiac. Certainly, we reviewed the data a few years ago. There was nothing to suggest there was an increased risk of diabetic ketoacidosis in individuals to fasting in Ramadan. And we didn't find that actually DKA risks go up or DKA numbers go up in Ramadan. And by extension, we did try and look at SGLT2 inhibitors as well, and we didn't find that they increased the risk of DKA either. Obviously, data is growing and things might change. But again, important thing is as long as sick day rules are being followed when it comes to SGLT2 inhibitors, then we're keeping risk at a minimum. Diet is just as important as anything else, and the old idiom of you are what you eat holds true for a lot of different things. Now, when it comes to Ramadan, the type of food that's consumed often when opening the fast perhaps might not be to a dietitian's or indeed a healthcare professional's top choice. However, we understand that individuals have been fasting, and opening the fast is a time to look forward to. So the important thing to understand is the type of foods that one might be likely to consume, and identifying whether these foods can be consumed without any restriction or whether modifications need to be made or are kept to a minimum. Just to help understand quantities of food, because sometimes what happens is psychologically speaking, people might think they're fasting, so they might want to eat more, or they might subconsciously eat more because they're not going to be eating for periods of time. Important thing to understand is that if you're fasting for only 12 to 13 hours, you're not going to be fasting for as long a period as you realize, and often during that period of time you may subconsciously do less activity or make an active effort to do less activity as well, so the calorific requirements might be less. And it's important to understand that calories and nutrition aren't necessarily one and the same. Calories refer to the energy that one is acquiring. Nutrition is more than that. It includes the vitamins and the healthy foods that are important and necessary to optimize bodily function. And this highlighting here that when it comes to carbohydrate in particular, you can see that, for example, broadly speaking, all 4 items shown, basmati rice and a plate of it, a couple of chapatis, 2 glasses of orange juice, or 500 ml bottle of Coca-Cola, full fat branded stuff, they're all broadly speaking have very similar calories when it comes to the carbohydrate side of things. They might all weigh or look differently. They have differing degrees of protein within it as well, and equally as well, depending how, for example, the chapatis are prepared, there might be oil involved, there might be some fat as well. Carbs and Calories is a great app or resource for healthcare professionals to direct patients to if they want to understand the idea of calories and nutrition in different food items or indeed different meals. So when it comes to the suhoor or the keeping of the fast, I'm just showing you here something that looks very similar to that you might find in a 2-star hotel, or you might receive in the morning when you're admitted in a hospital, where you have some toast, you have some cereal, you have some juice, and you may have a cup of tea or coffee. So there's about 100 grams of carbohydrate there. So it's very carbohydrate heavy, which in and of itself might not be an issue depending on the type of day you intend to have. But for a number of individuals with diabetes, that might be a bit problematic, particularly if there's a lot of refined, quick-acting carbohydrates as part of that. And there's also jam there hidden behind as well. So there's plenty of carbohydrate there. And also milk has carbohydrate. Sometimes individuals forget this, particularly if they're having a full bowl of cereal. Now, an alternative suhoor which provides similar energy content, but perhaps slightly less carbohydrate content, is what's shown there. It includes protein, includes a mixture of fruit and vegetable as well. And the important thing to understand is not all calories are derived from carbohydrate, but consumption of large quantities of carbohydrate with individual with diabetes can be challenging to manage, either in terms of the spike or even in terms of with insulin, for example, or even if it comes to the type of medication that they're taking and how that spike might look. Dietary advice is very straightforward, and there is a resource that we have from on behalf of Diabetes UK that's been delivered by Salman Maher on this that goes into things in more detail. But briefly speaking, a healthy balanced diet remains, whether it's Ramadan or out with, and you want to have food from all foods from all food groups, so starchy carbohydrate, milk, dairy, proteins, fruit and vegetables. When it comes to hydration, trying to avoid fizzy drinks and juices. When it comes to preparing your meals, try and grill and oven bake rather than fry. Just to understand the concept of frying, I often use the word describe or define frying as boiling in oil, because you are in essence cooking the food in boiling oil and the food absorbs the oil. So although the food tastes good and gets cooked, though the calorific content goes up because you're absorbing the oil within, and the oil has calories. Generally, having 2 meals a day might be easier, and not to overindulge and have maybe just one large meal, although it might be more practical for some individuals, depending on what they're doing during the day as well. For example, the meal before dawn, you want to have low GI glycemic index foods. That means foods that break down a bit slower. This will keep you feeling fuller for longer, so you won't feel the need to eat more when you keep the fast. The meal at dusk, so having a slightly more high GI index foods are good because it helps give you that energy boost that you might be looking for, particularly if you're looking to pray in the night. Keeping yourself adequately hydrated is very important as well. And the important thing with this is that you don't need to consume all the fluid when you immediately keep the fast, or indeed as soon as you open the fast, particularly at this time of year when you have potentially 11 or 12 hours between the opening of the fast and the keeping of the subsequent one. So be sensible, try and consume somewhere between 1.5 and 2 liters, unless you're taking on more physical activity that might involve sweating, or equally you might need to take a bit less if you've got kidney or heart issues. But again, you should be speaking to your specialists in that regard or being guided by a healthcare professional. When it comes to actual medication itself, I'm not going to go through things in a granular manner, but just touching on some headlines. Metformin, generally speaking, is safe, and unless there's changes in the size of meal, for example, or the fact that an individual might be taking tablets 3 times a day ordinarily and perhaps not twice a day, you're generally looking to take the tablets when you open the fast and when you keep the fast. You tend to take the bigger dose when you open the fast, because for a lot of people, the bigger meal is when you open the fast. And if you're taking 3 times a day, you might actually combine the afternoon and evening dose with the opening of the fast. Archibos, no real changes needed. TZDs for those few patients are on, again, very little to worry about, and same with DPP4 inhibitors, and they can be taken at either the opening or the keeping of the fast or any time between the two. Sulfonylureas are a bit trickier because first and foremost, they can cause the blood sugars to drop, and the sugars will continue to drop rather, even if you don't eat much carbohydrate, because they are purely having an effect on the pancreas, and it does not factor in what is being consumed or has been consumed. Sulfonylureas might be once daily in terms of the longer acting ones, or generally speaking, glycoside is twice daily is the most common one used. In terms of how one manages it, it very much depends on the actual dose itself, how much they're eating, the gap between the doses. Generally, what we say is you take the normal dose when you open the fast, and firstly because the meal being consumed tends to be larger. Secondly, they might have something to eat later on, and equally, if they do run into any trouble, then obviously they can deal with that without compromising the fast itself. When it comes to keeping the fast, they may actually take a lower dose because they're only going to be eating one meal, and then the next meal won't be again till the next night, so they might take less. If they're having a very large meal, it can be problematic because the glycoside itself might last 12 hours. So even though the amount of calories being consumed might be the same, because it's taken in one go, it might be a bit tricky. So this is why portion size is important. SGLT2 inhibitors and GLP-1 receptor agonists. These are the new kids on the block. And the important thing with the former is, as I mentioned, is that it's not just used by diabetologists, but cardiologists, renal doctors, GPs who use managing individuals who have more than one of these indications could be putting patients on these medication. Generally speaking, if they're started 4 weeks in advance of Ramadan, there's no real issues. It's important thing to understand is that the glucose effect only persists until the kidney the eGFR has fallen to around 45. After that, there's no glycemic effect, and you're largely looking at the sodium effect of the medication, so behaving more like a diuretic. It's important to understand that, paradoxically speaking, the risk may actually be higher with normal renal function than with lesser renal function. But an important thing to understand is that if the indications were appropriate at the beginning and they've been on it for a period of time, they're fairly straightforward to manage. Semaglutide tablets are the trickiest tablets probably to manage. Although GLP receptor agonist therapy comes in the form of injections, be it daily or weekly, and there are a number of individuals that take the semaglutide tablets. The challenge is to maximize bioavailability without compromising fasting or eating habits or patterns in the month. You generally want to take the semaglutide after a period of 6 hours of fasting minimum, and you want to generally leave 30 to 60 minutes after taking the medication before eating. So it can be quite tricky. It might be that individuals are happy to open their fast maybe with some water and take the tablet and then wait 30 minutes, so pray the fourth prayer and then have something to eat afterwards. For some people that might work absolutely fine. For other individuals it might not be possible, in which case the advice might be, if they're able to allow a gap after opening the fast before keeping the next fast of a few hours, and then just waking up half an hour to an hour before they intend to eat before starting the fast, that's the other option. It is tricky, and it's about the individual working out what's best for them. If they've been having very desirable benefits from treatment, you might not wish to stop the treatment for the individuals during this month because the glycemic control might be compromised. In terms of dose titration, you may wish to avoid increasing the dose just before or during the month because of the GI side effects, which can sometimes be associated with increasing the dose. You may wish to defer that until the month is over. So just highlighting the fact that when it comes to the SGLT2 inhibitors, there are 3 indications, and that can and you've got the holy trinity of cardiac disease, type 2 diabetes mellitus, and chronic kidney disease. As mentioned, the renal function has a part to play in terms of the role of the medication and the efficacy it has when it comes to glycemic control as it drops. Finally, insulin. Insulin therapy or treatment in and of itself is not an absolute contraindication to fasting. It very much depends on the type of insulin the individual is taking, the reason for the insulin, for example, is it type 1 diabetes, type 2, or steroid induced, for example, and the duration of the fast and how much they're eating, so on and so forth. What I would say is that generally speaking, basal insulin is the safest, along with hybrid closed loop pump therapy. When it comes to twice daily insulin, that tends to be the trickiest, particularly when they're longer fasts, because the insulin lasts 12 hours and it can be difficult to manage things. Generally, for those individuals, take the morning dose, even if it's a reduced dose, number of units at the start of the fast, and you can take the other dose when you open the fast. Basal bolus is fairly straightforward to manage. Sometimes you may wish to reduce the morning dose or even drop the basal when it comes to the basal bolus side of things. As mentioned, twice daily insulin is the trickiest. The hybrid closed loop is the safest and easiest, because for those individuals that are familiar with hybrid closed loop pumps, the short of it is that you don't need to worry about your basal rate. Things are taken care of, and you're simply giving bolus information and in relation to how many grams of carbohydrates are consumed and making sure the ratios are appropriate. In terms of you and your patient, it's not just about having that consultation before Ramadan, but it's also during Ramadan and providing that support network that might be needed to help them going. Equally, even if it involves just a bit of reassurance to say, yes, fasting is appropriate, or if indeed struggling perhaps to stop fasting, either to take a break or to stop fasting for the rest of the month. And after Ramadan, to document how things went or what happened, so that you know for next time what to look out for. And equally, from a clinician's or a healthcare professional's own experience and expertise, closing the loop is very important, and documenting your findings is also important, because it might not be you that's seeing the individual in the subsequent Ramadans. Other things to factor in when it comes to your patient: will they actually check their blood sugars? Will they follow the DVLA guidance? Are they prone to UTIs? When they're having problems with hypo-awareness, are they going to use flash glucose monitoring? Will they act on it if their sugars are low, even if they're not feeling low? And again, the infrastructure. When it comes to driving, and I'm not going to go through things in too many details, the reference is there, and the guidance is also available in the Greater Glasgow and Clyde guidance. It's a good framework to refer to when it comes to generally managing your patient and risk stratification, how to navigate things, particularly if the patient has been classed as high risk and intends on fasting and is unlikely to follow your advice. It's not about ending the consultation, it's about ensuring that you provide them with responsible advice and safety advice, and then documenting findings afterwards. The first part of the flow diagram focuses on stratification, and if stratification indicates higher risk and they appreciate that, the alternatives to consecutive fasting during Ramadan, be it intermittent fasting, be it fasting with another time of year, or if there's a perpetual risk at play. And likewise, if the advice has been given not to and they're still wanting to, going through DVLA guidance, particularly when it comes to insulin and sulfonylureas, and documenting findings. A few cases to wrap things up with. So the first case is a 64-year-old gentleman who first came my way back in 2014. That's when fasting was in July at its peak, pretty much. He had type 2 diabetes, he had reasonable glycemic control, but he was on basal insulin, and he had cardiac history. And remember, this was at a time when SGLT2 inhibitors in particular were not indicated for cardiac disease. He'd had a recent MI in the run-up to in a few months preceding Ramadan, and he was very keen to fast because he worked in the mosque. And the cardiology consultant had referred to the diabetes consultant, who had actually passed the case on to me because they felt I had more experience in this area. So his intended plan was for the sunset meal to be the largest meal of the day, and he was going to have a pre-dawn meal as well, but he wasn't necessarily seeing any change to his physical activity. So what we said was, we agreed that no, he could fast, and that he would take the larger meal when he opened the fast, the lower dose when he kept the fast, dropping his insulin dose down by about 40% in the first instance, just because we really didn't want, no one wanted to make sure that we'd be safe about things. He would check his sugars at sunset before he kept the fast and also during the day. And I would contact him to see how things go. And this is because it was one of my first cases I was involved with. In the end, we actually increased insulin over the course of the month because we realized that he actually needed a bit more. And his HbA1c in October, so about 6 weeks afterwards, was actually 56, so had improved. Case 2 is an example of a 46-year-old lady when Ramadan was in June, so again, fast for long. She had type 2 diabetes the year before. The HbA1c was 84, and just before Ramadan started, HbA1c had fallen to 54, and that was because she'd commenced Victoza, GLP-1 receptor agonist, and lost some weight. The issue with her, however, wasn't so much the glycemic control, but that she experienced a lot of thirst, and whenever she fasted, she would get UTIs or urinary tract infections, even in the winter. Heartburn was also an issue. So because she couldn't even fast in the winter, she feeds those in need. So for every day she doesn't fast, she feeds a poor person. And unless those circumstances were to change, this would be what she would be doing moving forward. Case 3 was an example of a gentleman in his 30s, and again, when Ramadan was in so that's 2013, so that's supposed to be July to August. They had type 2 diabetes mellitus. They were on oral therapy. The issue with him wasn't his diabetes control per se. Well, it probably was because he had a foot ulcer, but in terms of the acute issue at hand, it was his foot ulcer. It was painful and it was taking time to heal. But if he wasn't going to take his analgesia, how would that affect his healing in terms of the posture that he would adopt, and would this delay healing? So what we advised was that he would fast in Ramadan, but take analgesia and as needed any antibiotics that the foot team might advise. And when the foot was better, or when fasting would be compromised by medication, he could make them up, for example, in the winter, either that year or in a subsequent year. Case 4 is an example of a gentleman who had chronic kidney disease, who spoke limited English, who had reasonable control for his diabetes, and he was on gliclazide, metformin, and Insulitar, once daily long-acting insulin. He used to check his sugars once or twice a day, and he had CKD3. He didn't drive. The agreed plan for that Ramadan was that he wouldn't fast in the summer, but would make the fast up in the winter because it was just too tricky. And actually what happened was, because his kidney function deteriorated and he became frailer from 2020 onwards, he is no longer fasting and feeding poor people. And this is an example of how circumstances can change for an individual, and it might not be the diabetes per se, but other factors. The final case is a gentleman who at the time in 2016 was 28 years of age, and he'd been diagnosed with type 1 diabetes in January of that year, and his HbA1c was reasonable in the month before. He was on NovoRapid and Lantus. He was likely to be honeymooning because his insulin doses were dropping at times. Pre-Ramadan, he was on the above one of his doses listed. He had done a local patient education course for type 1 diabetes and is very enthusiastic about his diabetes. He runs his own business and he needed to drive for work. He was in frequent contact with me and the diabetes nurse. The agreed plan for 2016 Ramadan was they would keep all the fast, but he would reduce his basal dose of insulin, and he would take a very small dose of NovoRapid with his keeping of the fast and opening of the fast, and he would check his sugars frequently, in particular when it comes to driving, and he would be willing to break the fast if necessary. Afterwards, his glycemic control was pretty good. And from 2019 onwards, his sugar control has been not too bad. He manages Ramadan with application of ongoing principles. He has a Libra, and he's now being considered for closed loop hybrid pump therapy, which is useful and very important because this will actually make the risk even less as he moves forward. So even though he's someone who's becoming better at managing Ramadan and fasting getting shorter, the fact that he's going to have a hybrid closed loop pump will reduce that risk even more. So just moving forward, important things about raising awareness, actively risk stratifying patients, perhaps being more opportunistic, not waiting 4 to 12 weeks before Ramadan comes on, because you might not see them before that. So again, even if you're not having the exact plan, just giving some things to think about so they can contact you back later, or for the primary care team to look into. Need for dietitians or of a similar ethnic or religious background as the patient. I think often you find that one of the barriers is when it comes to the food, and they say that you don't understand me. The important thing, just to conclude, is that it's not 30 days of feasting and 30 days of fasting, 30 nights of feasting. The need for a multidisciplinary approach, starting early, an opportunity for weight loss. Here are some Diabetes UK resources. These are the QR codes which you can scan for the different resources. And here are some resources when it comes to other related conditions. So, for example, the BMJ paper, the Ramadan Compendium, which was made reference to at the start, and that's a good starting point because it also talks about a bit about acute illness as well, and the number of different papers that we have published and have just been accepted for publication. And this again gives some credibility to the work that we're doing and some peace of mind as well to the specialists and healthcare professionals.
If you would like to find more resources to support your patients during Ramadan, visit www.diabetes.org.uk/Ramadan. Here you'll find Ramadan and diabetes support videos in English, Urdu and Sylheti, as well as a webinar on healthy eating during Ramadan with diabetes dietitian Salma Miha of the British Islamic Medical Association. We also have fact sheets co-produced with the British Islamic Medical Association, which are available to download in different languages, as well as advice for imams.